It's a great pleasure to be here. Thank you for the invitation. I'll be talking about challenges and complications of intraarterial chemo for retinoblastoma. My name is Pascal Jabbour, and I'm a neurosurgeon at Thomas Jefferson University Hospital in Philadelphia. Those are my disclosures. None are related to what I'm going to be talking about. So if we're going to compare IV chemo to intraarterial chemo, if we look at IV chemo, it's a little bit like this traditional classic model of when you go to order something, it's going to be dispatched. And then if it's being ordered from a different country, it's going to be sent, then go to a dispatch center, and then it's going to be sent out for delivery. So a lot of waste of resources and inefficiency. As compared to IAC, I can compare it to a little bit what you're going to see here, which is Amazon Prime Air. Here it is, you're putting the order. The order goes directly to the drone, and then automatically the drone goes in and lands in front of the house where they did the order. And here it is. It's a targeted procedure, and they delivered the order directly to the house. So this is what we do with IAC, as you already know. And then since we started, we've learned a lot. I'm going to go quickly over the technique. This is now, that's the version of the technique that I do right now. We went through different versions. We've been doing this for more than 10, 11 years. And now I go with a microcatheter from the groin all the way up with a marathon microcatheter. And you see here the microcatheter going up, and then catheterizing the vessel. The first challenge start here technically to catheterize the vessels with only a microcatheter without a guide catheter, and then all the way up to the ophthalmic artery, as you see here. And here it is, we're delivering the chemo over half an hour. And then at the end, putting pressure at the groin. And you see here, I'm showing you jumping to the left side can be a little bit challenging to get the microcatheter go from the right to the left. Even putting groin pressure is as important as the procedure. Those are little babies. You see here, if I put a little bit more pressure, as you see, the SAT curve will flatten here, which we will have an ischemic leg. So you need to put barely some pressure, but at the same time, not to cause a retroperitoneal hematoma, which in babies can be a disaster. We looked at our series, and we published this paper on the use of alternative route of delivery of IAC. And this is in cases where either the ophthalmic artery is occluded or the ophthalmic artery is very narrow, and for technical reasons, we're not able to catheterize it. So we looked, and we saw that in 6.4% of the cases, we did an alternative technique. Total of 42 cases, 22 were middle meningeal embolization. So we went through the middle meningeal with the collateral to the ophthalmic artery. And then 20 of them, we did balloon, which is the old Japanese technique. There was no complication related to the alternative technique itself. And the overall complication was 0.6%, as you see here: ophthalmic artery spasm, carotid spasm, anaphylaxis, and one case of carotid dissection, but with no clinical consequence. Those are how we did the cases, and this is every case showing how many alternative treatment we did between balloon and middle meningeal. As you see here, that's the middle meningeal artery, the collateral to the ophthalmic artery. As you see it here, this is the technical case that we published. And this is the Japanese technique. As you know, we go distal to the ophthalmic artery. You see here an ophthalmic artery with a proximal stenosis. We inflate the balloon and we inject the chemotherapy directly in the internal carotid artery. More and more, we've been doing a transradial approach in those kids. It makes a big difference. They don't have to lay flat. You don't have to sedate them. Those are little babies, and they sedate them for 6 hours not to jump around. So this is also challenging, but it is feasible. Same thing you see here. That's the catheter in the radial artery of the baby. The sheath is a 4 French introducer that we use as the sheath. And this is the microcatheter going directly from the radial artery all the way up. What I've used here, either a marathon or a Prowler 10. As you see here, it's doing the turn, and here it is catheterizing the ophthalmic artery. The left side may be challenging a little bit, but it is feasible. And then it makes a big difference. Kids an hour later are able to walk and go home. As you know, in IAC, mainly thromboembolic events and occlusion of the ophthalmic artery is the main issue. And we've learned a lot since the beginning. We changed our techniques, and we had this incidence rate drop a lot. This is one of the earliest publications showing that there is vascular pruning, retinal vessels 10%, choroidal vessels 10%, ophthalmic artery 5%. And then recently we looked at the vascular events after primary IAC in early and recent eras. And as you see here, this drops completely to close to zero. I don't remember the last time we had any of those events. What about reflux of chemo in the internal carotid artery, and how much reflux to tolerate? And this is very important because once you have a little bit of reflux, you can either keep on going, or if you decide to stop and be more aggressive, this is when you're going to start having complications. If you have a lot of reflux, you're going to catheterize deeper the ophthalmic artery. This has been associated with ophthalmic artery occlusion. So we looked at categories of patients with reflux, and interestingly enough, there was no difference in tumor regression or enucleation rate with a little bit of reflux, variable reflux, or no reflux at all. Now here, of course, we're talking about tiny reflux that you see. We're not talking about doing a run and seeing all the contrast in the internal carotid artery and nothing is going in the ophthalmic artery. Those are cases where you have to see the ophthalmic artery all the way to the retina, to the choroidal blush, and with that you have some reflux. So you have to first see all the ophthalmic artery. So as I said, interestingly enough, we looked at those cases, and there's no difference in outcome with enucleation rate or progression of the disease. Another challenging subcategory are patients that are really young, babies with that are less than 10 kilograms. Those are a challenging category. We looked at 222 IAC sessions on those babies. And actually, we saw that babies less than 10 kilograms will have the same procedure complication rate, same failure rate, same enucleation rate, and same complete tumor regression. So there's no difference, and we should be able to treat aggressively those babies that are less than 10 years old. The only thing that we saw that was different is the rate of aborted procedure. This is for access side problem, and what happens is the procedures were aborted, but then the patients was brought back a couple of days later, and we were able to do it. Those are, we looked at cases of less than 4.5 kilograms, those are really challenging, between 4.6 and 6 and above 6. Again, there was no difference in fluoroscopy time, mean radiation time, cumulative radiation exposure in those kids. Those are the number of IACs needed, which were similar. What about the incidence and predictor of ophthalmic artery occlusion in IAC? We looked also at our series, and those are the patients at the beginning where we changed some technical details, which at the beginning we used to go 1/3 of the ophthalmic artery. This was just the first year. We haven't done that for more than 10 years. We barely engage the ostium of the ophthalmic artery. We don't use any towels anywhere. We put ioban everywhere to avoid any microcotton emboli in the ophthalmic artery. And when we looked at that, the ophthalmic artery occlusion at this point is only correlating with the total number of IAC treatment. It's not correlating with anything else. I think it's the challenge itself is we have so much, a lot of choices. Is the choice of the treatment modality is also a challenge. Again, I'm lucky to be working with a world expert in the field, Dr. Shields. She will be the one deciding which treatment modality to use. But as I said, there are so many treatment modalities. And the most important thing is to be able to be aggressive with IAC, but at the same time, to avoid putting the patient at risk. And this is a very important paper, which was a collaboration with the biggest centers in the world, where we looked at metastatic death in retinoblastoma, looked at 1,139 patients, and there was only 3 deaths due to metastasis, none of them in the US. So it's very important to, yes, be aggressive doing IACs, but at the same time, shouldn't put the patient at risk of having any metastatic disease. And this is also challenging and is very important. I think after so many cases of IAC, I think at this point we are able to decrease the complication rate to the minimum possible and increase the efficacy of the treatment and really make of it the gold standard for retinoblastoma treatment. Again, thank you very much for the invitation.